It's just a huge honor for me today to be podcast interviewing Dr. Todd Hanna, MD, DDS, FACS. He's a double board certified dual degree MD, DDS, Oral Maxillofacial Surgeon, and Head Neck Reconstructive Surgeon. He is a double fellowship trained in Head Neck Oncology Surgery and Microvascular Reconstructive Surgery of the face, head, neck, and jaws. He maintains a private practice in Midtown Manhattan and a faculty appointment at the NYU Head and Neck Institute at Lenox Hill Hospital, Northwell Health System, formerly North Shore-LIJ, within the Department of Head Neck Surgery. Dr. Hanna was born in New York City, where he attended primary and secondary school. He graduated from New York University with a Bachelor of Arts in 2002, taking a pre-med curriculum and studying in Florence, Italy. After he performed clinical research at Bellevue Hospital, NYU, with the Department of Pathology, he then graduated the top of his class from both NYU College of Dentistry and the University of Alabama at Birmingham School of Medicine. He was inducted into the Omega Kappa Upsilon Honor Society and won 2 Alpha Omega Honor Society awards. While at NYU, he served as vice president, tutored classmates, and had the highest national board exam score in his class and in the 99th percentile nationwide. Dr. Hanna was accepted into the prestigious 6-year Oral Maxillofacial Surgery residency at the University of Alabama at Birmingham, regarded as one of the best in the nation. Here he learned full-scope face, jaw surgery with emphasis on orthognathic, cosmetic, and reconstructive surgery. During the time he completed a 1-year general surgery internship, he won the Clinical Performance Award as an intern and served as chief resident in his final year. He then completed the fellowship for Maxillofacial Head Neck Oncology and Microvascular Reconstructive Surgery at the University of Maryland Shock Trauma Hospital in Baltimore. Here he was trained in reconstruction of the face, head, neck, jaws, with free tissue transplant surgery for tumor and trauma-related defects, as well as treating cancer of these regions. Dr. Hanna then received a rare opportunity for a second fellowship in Head Neck Surgical Oncology with the Department of Otolaryngology, ENT, at the NYU Head and Neck Institute, Northwell Health-Lenox Hill Hospital in Manhattan. Here he was trained in full-scope head and neck surgery, including minimally invasive thyroid, parathyroid, melanoma, robotic surgery, tonsil cancer, and facial reconstruction. Dr. Hanna is likely the only surgeon in the nation to have this combination of training. During his training, Dr. Hanna was directly mentored by past and current presidents of the American Head Neck Society, American Academy of Cosmetic Surgery, American Skull-Base Society, American Board of Oral Maxillofacial Surgery, and the American Association of Oral Maxillofacial Surgery. Dr. Hanna is a diplomat of the American Board of Oral Maxillofacial Surgery, a fellow of the American College of Surgeons, and a candidate fellow of the American Head Neck Society. He has authored publications in peer-reviewed journals on facial reconstruction, tongue reconstruction, oral cancer, head neck cancer, microvascular surgery, fibula-free flap jaw surgery reconstruction, facelift and cosmetic surgery, dog bites, and lip augmentation. He has participated in medical outreach programs to third world nations, as well as underserved American communities. Dr. Hanna values communication and compassion and possesses an aesthetic sense. He lives in Manhattan, where he enjoys spending time with his family and follows Formula One racing. I posted one of his cases on Instagram, and my buddy, Dr. Andonis Tezerides, who was on the show, he was on podcast 1010. He said, Howard, that's my buddy, Dr. Hanna on Instagram, who has 21,000 followers at Dr.Hanna. And that case is just unbelievable. It's a huge honor for you to make time to come on my show today and talk to my homies. My gosh, you just elevated the status of this show at least 3 notches. Man, I could talk to you forever. I just want to start on his website. His website is Dr. Todd Hanna, MD, DDS. So Todd Hanna, Hanna, then he's an MD and a DDS. So toddhanna.com. And he's got just a unbelievable list of procedures that he does. And I just want to start at the far left, because our listeners, a quarter of them are still in dental school, and the other 3/4 are all under 30. So I want to start with oral surgery. What's hot and what's not in orthognathic surgery? Is that still a very invasive? Are they doing less of that from when I got out of school in 87 to now, or the same amount?
Good question. So I think, first of all, thank you so much for having me on the show. You're the legend, and what you're doing with the show and the podcast and the website is pretty impressive. So thanks for having me. Secondly, so with regard to the oral surgery and orthognathics, I think what we have seen in it was in the 80s. I think it was quite popular. I think people were realizing the aesthetic benefits that you would get from it. Prior to that, I think people were doing a lot of nose and chin augmentation when patients really would benefit more from orthognathics. So there was a guy in Pennsylvania, and I'm blanking on his name, but he was both an oral surgeon and a plastic surgeon. And he really did a lot of the earlier work in showing the aesthetic benefits of orthognathic surgery, as did a guy named William Bell, who practiced out of Texas, and now has a son, Brian Bell, who's a head and neck oral surgeon out in Portland. But so there were a lot of people that pioneered, and the 80s were kind of like the heyday for orthognathic surgery. And then over time, I think what happened, and quite candidly, I think what we saw was the insurance companies were struggling, or people were struggling to get the reimbursement from the insurance companies for it. So it really wasn't as sustainable for surgeons to offer these surgeries for a while. So I think in the 90s and maybe early 2000s, you saw orthodontists going back to doing these huge compensations to get patients into, the pseudo class 1 occlusion without surgery. But I think what we've seen now is kind of a swing back to orthognathic surgery for a couple of reasons. One is the use of virtual surgical planning, where we could use 3D computer images to actually do the surgery before even going into the operating room. You do it on the computer. It's added a tremendous amount of predictability to the procedure and has decreased the operating time and has made the procedures technically easier in many ways. So I think that with the advancement of that, we're actually seeing an increase in orthognathic surgery lately. At least I have in my practice over the last couple of years. And also, I think it's, to some degree, becoming a little bit more on trend. I think the aesthetic benefits are undeniable, and I think patients are becoming more informed about it. So, those two things, I think, are resulting in an increase in orthognathic surgery at the moment.
Same question. When I got out of school in 87, the ENTs were all telling everyone that if you're snoring, come into my office and we'll take a carbon dioxide laser and clean out the back of your throat, and that faded away. Where is sleep apnea surgery today?
Also, great question. So I have a lot of friends and colleagues who are ENT, and they do sleep surgery. Traditionally, historically speaking, now everything's different now because there's a lot more crossover as to procedures that people do from different specialties. But historically, the otolaryngology specialists who treated sleep would do things like septoplasty, UPPP, which is a reduction of the uvula and the palate, and the posterior palate. And the
what's that called?
UPPP.
UPPP?
Yeah, uvulo-pharyngopalataloplasty, or uvulo-palatal-pharyngoplasty, which is can be a very uncomfortable post-operative experience for patients. And that's, to some degree, that's not quite as, that's fallen out of favor a bit. A person that I trained with in Alabama by the name of Peter Waite did a lot of studies on maxillomandibular advancement for sleep apnea, which is basically orthognathic surgery, but with these large advancements. And most people believe that is the most successful way to treat sleep apnea in many ways.
What's it called, the most successful way to treat?
In MMA, maxillomandibular advancement, MMA.
Okay. MMA.
Yeah, many people believe that's the most successful.
And are you doing those?
Yeah, I do those.
And what do you think? Do you think it's it's the way to go?
I think in most cases it is. I think I tend to shy away from doing just soft tissue UPPP work. I think you could end up giving patients a insufficiency of the palatal tissue, and they could have reflux, hypernasal speech, things like that. I think that the MMA is the best way to go in most cases, and most patients that have sleep apnea are either have a large amount of tissue around the throat and jaws, or they have retrognathic skeletal development where they actually need advancement of the jaws. But I think the true way to treat patients, the best way to treat patients, is really a combination of where their deficits lie, meaning if it's skeletal, then you need to advance their jaws. If they have an elongated palate, then in that case, a palatal reduction is warranted. So, I think that you have to kind of tailor it to patients and where the root of their problem lies. That being said, I think in most cases, the jaw advancement, the MMA, is the most predictable and gives the best result.
Nice. This is just so much great quality information. It's gonna be hard to keep up with you. So mandibular advancement surgery for sleep apnea, maxillomandibular advancement surgery (MMA) can be an effective treatment for obstructive sleep apnea. And MMA, the bones of the upper and lower jaw are repositioned to relieve airway obstruction. Common sentiment has been the MMA is reserved for patients with craniofacial dysmorphism, which is mandibular retrognathia. Do you agree with that sentiment?
Yes, very much.
Okay. So next one, gosh, it seems like when I asked you the first question about orthognathic surgery, immediately it goes to the reality of insurance. I mean, they invented X-rays in the 1840s, but the dentist didn't even look at it until dental insurance came along in 1948 and said we cover X-rays 100%. And then, like a domino effect, the whole country in Europe all got X-ray machines. And when you said they orthognathic surgery, when the insurance reduced their reimbursement rates, it started to go away. And so when you go around the world, when you go to three of the greatest cities in the world, like Tokyo, Paris, London, the national dental insurance plan only pays $100 US for a molar root canal. So you go to those countries, and I podcasted live dentists from those areas. They say, well, we can't do a molar root canal. We have to pull the tooth and do an implant. And so when you go around the world, all the dentists are getting into implants and Invisalign because the insurance company isn't setting the fee. And they find that they're using their insurance pool of population. They're trying to upgrade one implant a week or one Invisalign case a week. So I know all my homies listening right now want to know what your thoughts are on dental implants. What would you say to a kid who's in dental school or just got out and wants to learn how to start placing dental implants?
Oh, I mean, absolutely. I would say that should be, that shouldn't even be a second thought. I think if he wasn't thinking about placing dental implants, he should be concerned, because if you're not advancing with the specialty, then you're going to get out and you're going to be well behind the curve. So I think that if you look at, now every community is different, but if you look at New York, where I am, I think a fair amount of general dentists are placing implants, as they should be. I have no problem with that. As an oral surgeon, you hear a lot of oral surgeons say, "Oh, it should be a specialist," or all that, but I don't agree with that. I think it's well within the scope for general dentists, and I think that it's part of the advancement of the practice. So yeah, I'm all for that.
So I know what they're thinking. They're thinking they always go to brand. They're like, well, what implant should I place, or where should I go get trained? Do you have any simple short list of you thought this out where they should learn more about placing implants?
So I think, most schools, I'd imagine it's some, by this time, even, when I was a student, it was already starting to be part of the curriculum where if you wanted to have the opportunity to do it, you could. I would imagine now most dental students actually have the opportunity to place implants before they graduate. But I think that it's an experience that they should have in their residency, whether they do a GPR for general dentistry or whether they do a specialist residency. They should be able to get that experience there. I know there are a handful of courses as well that many of the implant companies will hold. and many of the schools will hold as well, where they could get additional training. But I would say it's something that you should do in the residency.
You went to University of Alabama, and BioHorizons is right there in Birmingham. Is that an implant company that you like, that you're more familiar with, maybe because you were closer?
Well, yeah, we placed a lot of them in Alabama. It's a great implant. Other great implants and ones that are popular in New York, where the community here. Straumann are very popular. Nobel is still very popular. Like you said, BioHorizons. Those are some of the ones that I like.
My favorite, not that anybody's asking, is Straumann, because he came on the show. He was on the CEO Marco Gadola, and he's in Europe. So the only time we could meet is I was lecturing in Canada. And I said, forget it, man. I'm just going to stop my lecture and I'm going to do the podcast live. It was the only one I did live in audience. And it was amazing because the questions were just amazing. And there was no question that even got under his skin. He loved to hear what they were thinking, and just a great guy. And also they're number one, just like the biggest dental practices I see around the United States are number one for the same reason Straumann is. It's called M&A activity, which is in your backyard, mergers and acquisitions. Straumann has bought Neodent in Brazil. They bought MIS in Israel. They've been on this series of mergers and acquisitions. And right now, probably, last thing I read from Wall Street is, they're the number one implant place. And then when I go to these small towns, there'll be like 5 dentists in the town. And some old guy will retire and he'll sell the practice and bring in some highly energetic young kid that'll just crush you. And the smart ones just say, oh, I'll buy you out. Give me all your patients. And now my town's gone from 5 dentists to 4. And then 5 years later, it goes down to 3. And when I see some dentist that's my age, I'll be 57 this month, and he's got an office doing 2 to 4 million. It's because he did the mergers and acquisitions, and it's just it's so obvious for so many companies. So I want to get into some a very common question with these young kids is one of the controversies that they believe is whether or not if they're going to learn how to place implants, they need to draw blood. Do they need to draw blood and start doing all that stuff?
What do you mean draw blood?
Well, the PPA, they spin out and,
Oh, no, I don't know. I think that the literature on the benefit of like PRP and PRF for healing in that context is still relatively soft. Meaning, we know that there is benefit potential in blood product and stem cells and all that, but I don't necessarily know that we have an idea how to apply it in a way that it really translates to a better outcome. So, I think that it's very trendy. It's very popular now to use PRF and spin down blood product and to use that kind of as a membrane, if you will. But I don't know that it's necessarily something that's proven to really benefit patients, right? So I don't think so. I think people were placing implants without that for a long time, and they were doing quite well. They were very successful. So I don't think that should deter them from placing implants at all. Well, I don't think it's that hard to learn how to do either. To spin blood, all you need is to learn how to draw blood and then get a centrifuge. It's not a difficult process either. So
I think we should put a over-the-shoulder surgical implant placing graft in Alabama, where you went to school, and you'll be placing BioHorizon implants while we're playing Sweet Home Alabama at full volume. So Carl Mish was on the show, and it was the I think he was on episode 282, and just on YouTube, it had 13,000 views because he said that he didn't think he didn't agree with the platelet-rich plasma PRP and platelet-rich fibrin PRF. And oh my gosh, was that controversial? I mean, I don't know what else he could have said that got under the skin of so many people, but it sounds like you're agreeing with Carl.
It's not that I'm agreeing with him in that I don't agree with it. I think the literature supporting it is soft. So I think that it's not proven in a meaningful way to have a significant, if any, benefit. I don't think it hurts, but I don't think that it's proven that benefit. So if people are doing it and they find that in their hands it works better and they have good results, I think that's fine. But if you don't do it, or if you don't know how to do it, or you don't want to do it, I don't think that's practicing below the standard of care. I think the jury is still out on how effective it truly is, and some literature needs to be done so that we know. But I haven't bought into it 100%. I don't necessarily think that it offers much, in my opinion.
Well, you just walked in a perfect segue to my next question. You said the jury's still out. I noticed the jury is changing their minds on impacted wisdom teeth. There are oral surgeons in Germany that are very outspoken that Americans in specifically remove way too many wisdom teeth without scientific evidence. Where is the jury between your ears on the removal of impacted wisdom teeth?
Okay, so I actually have this discussion with every patient when they come and see me for a wisdom tooth consult. Most of the literature for how to treat impacted wisdom teeth came from either America or came from the UK, from England, or parts of Europe. And then other parts of the world seem to adopt the literature philosophy of one of those two nations. And I think not to bounce back to insurance or socialized healthcare or things like that, but I think in large part it was due to the European model of socialized healthcare, especially in England with the NHS Trust, and the private practice model in America, that may have been somewhat of the influence of the literature findings. But I think Americans historically took out wisdom teeth on just about everyone, whether they needed to come out or not. And I think that in parts of Europe and nearby countries to that, I think they were more, reserved. They would observe these wisdom teeth for longer periods of time. I think that the correct way to treat wisdom teeth is really somewhere in the middle, meaning we have a pretty good idea based on panoramic x-ray or cone beam CAT scan. We'll have a pretty good idea of which wisdom teeth are going to grow in a problematic way and which should grow in a normal way. And if they appear to be growing in a problematic way, I think it's better to treat them while the patients are young, preferably in their late teens and certainly before the age of 25, because after the age of 25, the complications from wisdom tooth removal start to increase based on all the studies. They all keep going back to that age of 25. But if they look like they're going to grow in a normal way, then there's no reason to remove them. So I'm kind of in the middle on that. I definitely think there's benefit to treating people younger, but I don't think there's benefit into just taking everyone's wisdom teeth out.
America has always been, I shouldn't say America, that's unnecessary to say it, but beauty. I mean, I don't know if they're going to the dentist for just mental health, they want to be prettier, or oral health. I mean, it seems like when I tell someone in Phoenix, you have 10 cavities and gum disease, they say, can you bleach my teeth today? And so zygoma implants, is that a thing, or is that just a Hollywood thing, or do normal people get that?
So when you say zygoma implants, do you mean like cosmetic cheek implants, or do you mean like zygoma implants for dental prosthesis?
Well, let's do both. Let's start with cosmetics and then implants.
Okay, so in the 90s and even up to the early 2000s, facial implants were becoming very popular, right? Like cosmetic implants, like cheekbone zygoma implants, if you will. As the filler materials have gotten better, meaning the types of filler that we use to augment the face, injectable filler, then the implants fell out of favor, because instead of going into the office and going to sleep and getting these 2 cheek implants, you could have an injector inject into your cheeks and get very good results without having to have a formal surgery. I think to some degree, some of the implants are kind of coming back into favor, because much like with orthognathic surgery, we're able to actually customize these facial implants now. And we could take a CAT scan and make, whereas we used to use silicone, we could use something called PEEK, polyethyl ether ketone, I believe, PEEK, and we could actually make a custom implant to the cheek in exactly the way that we want it, place it exactly where we want it, and get a very, very predictable, controllable result that way. So implants are kind of, custom implants are coming back in a way, or implants are coming back, but they're coming back in a customizable way. And that's part of the reason. That being said, it's still, the filler materials are still very good and very effective. So you see a lot of that as well. And in general, like you said, America is very cosmetically oriented. So all those procedures seem to be becoming more and more popular every year.
That is amazing. It says, here, let me tell you. It says polyether ketone, PEEK, P-E-E-K, is a synthetic material that was used initially in spine and hip surgery. Computer-designed, patient-specific PEEK implants for cranioplasties are a viable alternative when autogenous bone grafts are unavailable or suitable. But you're saying that you're CAD CAM designing these with software and making them customizable?
Yeah, I'm going to send you another link to one that I did for mandibular.
Oh no, I wish you would. I mean, you would kill on Dental Town. You should just start posting a few of these cases. I mean, my God, I've been on that thing 4 hours a day since St. Patrick's Day '99, and I mean, they would kill to see some of this stuff.
Anytime, yeah, I'll send it to you now, and then I'll certainly share whatever is useful on Dental Town. But yeah, the PEEK implants are really nice, and they're the thing that's different about them is they're customizable, meaning you can shape them, you can mirror them, you can mirror the left side to the right side, so they're symmetrical. You can do all these really cool computer things with them. So yeah, here's the link to another one for the mandibular angle, but you could do the same thing as that. You could do the same thing with the cheekbones as well.
And I just want to say for the record, everything you see on me is all natural. No one believes it. They all think it's all made. But so all on four. You were going to say zygoma for cheek implants, but what about zygoma? Is that a implants? Is that a big deal with all on four?
I mean, you could do it with all four. There's different ways to do it. I mean, I think the applications for it are few, but there are certainly applications for it. I think I've done a series of zygoma implant cases for patients who haven't been able to have traditional implants because of severe maxillary atrophy and failed procedures. They come to me, they've had 10 failed procedures at different places. They've no bone, really, really just poorly dense bone. So those patients are good candidates for either 4 zygoma implants, or you could do 2 zygoma implants and then try to get a couple anteriorly, 2 to 3 anteriorly, 2 to 3 normal implants anteriorly. But I've also used it for patients who have had maxillectomy, meaning they've had a tumor and their upper jaw is removed, and there's really no bone, there's nothing to even graft or to even, sinus lift or anything like that. And we can get them into some kind of functional prosthesis with zygoma implants. Most of those patients end up getting like a fibula transplant or some kind of bone transplant, but some of them aren't healthy enough to undergo that kind of surgery. So those patients, you could do zygoma implants, and that could get them something meaningful as well.
Wow, that must be just to have a maxillectomy. I mean, being a dentist and just hearing that, I mean, that just must be rock bottom. Can you have one of those and still be glad you're alive?
Yeah, you'd be surprised. It's funny. I was walking down the street on Sunday, and I walked by a couple, and I'm just kind of looking, just walked right by them, and I didn't realize it a second, but one of them was a woman. She was perfectly normal. One of them was a young woman who we did a maxillectomy on about 2.5 years ago, and she also had a fibula. And I hadn't seen her in a while because she was international, but she comes back and forth to New York. And I saw her walking through downtown Manhattan with her husband. And I had to like take a second look. She looked perfectly normal, from the outside. I'm sure there's tightness, and I'm sure there are things that she feels are different, but she looked perfectly normal. I had a max face prosthodontist do her dental prosthesis that went into the fibula. And you'd be pretty amazed at what we can do these days with regards to reconstructing them and getting them back to having a meaningful life.
I'm going to stay with all on four for a little bit. The thing I don't like about all on four is that when you go to all these major meetings, they always have some rock star showing a bunch of all on four cases, and then 90% of us go home and mostly do all on none cases. We're doing dentures, and then if we do implants, it's usually to replace a 6-year molar. And but all on four is controversial. There's some people that think that don't like it. Are you a fan of it or not a fan of it?
I think there's a lot of moving parts to it. There's a lot of coordination. There are some people that do the whole thing themselves. They do the surgery and the pros all themselves, and they love it. I think that when you try to coordinate all those moving parts between the surgeon, the restoring doctor, and all those things, I think it can sometimes seem to be a little bit. The juice may not be worth the squeeze as to what you're really getting. Whereas if you place the implants and temporize them and let things settle and then go back down the road and make them the permanent prosthesis, then, I don't see a major problem with doing it that way. So I'm not a huge fan of all on four. I don't think that it's something that doesn't work in some people's hands, but I think there's a lot of moving parts to it. So.
Okay, I was born and raised in Wichita, Kansas, and you definitely picked up the juice might not be worth the squeeze while you're in Alabama. That is not a New York statement. That is totally home brewed in Kansas to Arkansas. Sinus lift. One of the biggest controversies I've seen in the last 30 years regarding a sinus lift is it seems like in 87, the only successful sinus lift was the longest implant. I mean, the most successful implant was the longest implant you could put in a head. And then they seemed over time, they seem to get shorter and fatter, just like me. So does shorter, fatter implants, has that really reduced the need for a lot of sinus lifts?
That became popular, I'd say like 2008. I was hearing a lot about the Bicons, those shorties. Those seem to be popular. I think they kind of fell out of favor. In my own experience, if I can get an 8 or 10 millimeter implant in, I would certainly prefer that over a 6 millimeter implant. I think, most of the literature says it's really the width and not the length of the implant, but I think that what makes most sense to me is really the surface area of the implant. So I think it's a combination of length and width. So I err on the side of, if I'm at 8 millimeters, I'm comfortable, but I don't feel comfortable putting in implants that are less than 8 millimeters on posterior maxillary bone, particularly, which is not so dense. So I'm not a huge fan of the shorties and the Bicons. I don't use them.
So you like to have 8 millimeters for maxillary first molar implant?
Yeah, I do.
And what brand of implant would that be for you?
I typically most often use Straumann. I use Nobel as well. I'll use whatever the restoring doctor wants. But Straumann is probably the one I use most. And I use the bone level tapered SLAs.
The SLA Straumann?
Yeah, rock solid SLA.
Rock solid SLA?
Yeah, it's rock solid. It's a ROXOLID. It's like one word.
Okay, let's see what I have for that. Oh, rock solid. Okay, ROXOLID. And how long? Why do you like that one? And how long you been using that one?
I've been using them since I've been in practice. I mean, was it 4 years now? I've been using those. I like the kit. Meaning I like the system that they have. I've had great results with them. The science behind them is very clear, meaning it's not like this kind of speculative stuff. It seems like there's legitimate science behind it. And I find that most restoring dentists are very comfortable with the restorative portion and the restorative components. So it makes their job easier as well, which if their job's easier, that improves the success of the whole thing. So,
the next one is very controversial, but this is Dentistry Uncensored. I don't want to talk about anything everyone agrees on. I want to go right to the controversies. You're in New York, where Joan Rivers went in for a simple procedure, had IV sedation, and is no longer with us. And I cringe when I see these young dentists start getting into IV sedation, because 32 years of doing this, I've seen what happens to the dentist if something goes south, and they don't smile again until they, and one guy I know didn't smile again until he died, and another one became an alcoholic. What would you tell a kid who thinks, I'm going to go learn IV sedation?
Yeah. So, you know, I did a year of general surgery, which has 4 months of anesthesia, where we're intubating patients and giving them paralytics and all that. And, you know, we're putting people to sleep. I did, you know, the 6-year residency, oral surgery, did a couple fellowships, including one with an ENT group where we're in the airway. And even now, there are times where, you know, I have to like really kind of step back and really watch things carefully with sedation. It's not I don't take it lightly, even after all the training. So unless you have a lot of experience in that kind of thing, I do think it's something that I'd imagine could be overwhelming. I think that if they really want to learn how to do IV sedation themselves, then they should make sure they get enough training to the point where they're really comfortable, and also use sedatives that are limited, like use things like Versed or things like that. But I wouldn't start using propofol and ketamine and things like that. The other thing I'd say is another option, if they want to keep it in their office, is they could hire either a dental anesthesiologist or even just a general anesthesiologist to come in and put people to sleep if they want to do it that way, and that would take a lot of the stress off.
That's what I don't understand. I mean, why even where I practice in Phoenix, but everybody in my area calls it Ahwatukee, because it used to be a different city. It was annexed, and we just have one oral surgeon. And Greg Edmonds, great guy. He's been on the show, and but he even has an anesthesiologist. He says, "Why? I'm trying to do the surgery. I don't want to do another thing." And that's where I call crazy, because in the hospitals, and you work with several hospitals, you're not allowed to do the surgery and the anesthesia. So why is it only in dentistry from New York to London where a surgeon does the anesthesia and the surgery, and it's not done in any of the hospitals in the town that you're doing this in?
Yeah, I mean, it's a good point. You know, I spent, when I was a student, I spent 2 weeks in England, in Southampton, shadowing the surgeon, Barry Evans, who's an oral surgeon and did a lot of head neck stuff too. And he took me into his private practice one day, and he was doing them out of he was doing wisdom teeth out of an ambulatory care center and putting patients under general anesthesia. He wasn't doing it, but the anesthesiologist was. So I could see your point with that. I think part of it's largely related to the culture, especially within oral surgery. We learn IV sedation, we learn a good amount of anesthesia. So it is part of the culture and part of the training for that specialty. But, you know, I agree that I think these courses in IV sedation, you go for a 3-day course or a 1-week course, I think, you know, I would imagine that being very daunting, and I don't think I would feel comfortable putting people to sleep. You know, for 99% of the cases, it will be fine, but you get that one case, like you said, things go south and they don't smile again. You know, I think that the stakes can be very high with that. So.
Oh my God! Especially if the patient is named Joan Rivers. That should have been your first clue that you're going to be on CNN headline news. You know, the anesthesiologist that I talk to here, they're so mad at Michael Jackson because they say it's so hard to use propofol. Because when they say that, a lot of people in Phoenix say, no, that's what killed Michael Jackson. Do you get that pushed back in Manhattan?
More and more people ask what agents I use. Luckily, I don't use a lot of propofol. It's like a last resort medication. But yeah, people do ask. He definitely popularized the drug in a negative way.
Oh my God. So what happened? She's young. She just got out of dental kindergarten school a couple months ago. She sees a patient on their health history form. There's bisphosphonates. What should she be thinking about bisphosphonates?
I mean, it depends on which ones. The IV versus the PO versus the pill ones have different implications as to the risk of it's called ARONG. You know, it used to be called BRONG. The B stood for bisphosphonate. Now they call it ARONG, which stands for anti-resorptive. So in between they called it MRONG, which stood for medication related. But they all refer to related osteonecrosis of the jaws. So if she sees a bisphosphonate or any other kind of anti-resorptive that's correlated with osteonecrosis of the jaws, then she needs to do a couple things. One is she needs to understand which agent was given, the timeline of when it was given, if it is still given or if it was stopped, and then she also needs to discuss with. Usually, these are prescribed by a oncologist, because they're usually treating them for either breast cancer, which metastasized the bone, or something, or prostate cancer, which metastasized the bone, or sometimes just a endocrinologist who's treating someone for like severe osteoporosis. And they need to talk to the prescribing doctor and to see what the need is for the medication. In most cases, with PO anti-resorptives, and the patient needs oral surgery or they need an extraction or an implant, I'll recommend some kind of a drug holiday for anywhere from 1 to 4 months.
A drug holiday. I've never used that term. Now that has to be a Manhattan term. That has not made it this far west.
That's not. That I actually picked up in Alabama, but I think it's ubiquitous.
So you'll have them go on a drug holiday?
Yeah, for PO anti-resorptives, if possible.
Huh, that is amazing. So you call that bisphosphonate-related osteochronosis of the jaw is BRONJ, BRONJ for bisphosphonate-related osteochronosis of the jaw. BRONJ.
Now they call it ARONG, and the A stands for anti-resorptive. The rest of the acronym is the same.
Anti-resorptive?
Yeah, because what they found was even certain medications that they were given that weren't classified as bisphosphonates, but they were giving for the same reasons to maintain bone density in the skeleton, were having the same kind of effects on the jaws. One medicine that's well known that has done that is called Xgeva.
With Sally Fields?
I don't know about Sally Fields.
She's always the one on the commercials, isn't she?
Is she? I didn't know that.
I thought so.
Xgeva. Now I'll check that out.
Yeah, probably a millennial and never even remembered that movie. What was that? She was driving across the country with Burt Reynolds. They just robbed a beer truck or something. It was cleft lip and palate. That'll be my last oral surgery. But I mean, anything pique your mind on cleft lip and palates?
Yeah. So back to Sally Fields, though, she'll always be Forrest Gump's mother in my mind. I think that was one of my favorite. or the nun, the sitcom where she was the nun. So for oral, cleft lip and palate. So the common way that those are treated is they're usually treated by a cleft surgeon or craniofacial cleft surgeon for the early stages, meaning the lip and the early palate. And those are people that have done some kind of fellowship training in cleft and craniofacial. So it's either commonly it's a plastic surgeon or an ENT surgeon, and even now oral maxillofacial surgeons that have done fellowship training after residency in cleft lip and palate and craniofacial disorders. And those are the people that treat the initial cleft issues with the infants. Typically, the lip is done at somewhere around 3 to 4 weeks. I believe it was 8 weeks, maybe. I think it's actually 8 weeks. And then the palate's done somewhere around 9 months, and so on. The oral surgeon typical oral surgeon, meaning the non-fellowship trained oral surgeon for cleft, can come into play later on in the child's life, usually around anywhere from 9 to 12 years old, when the alveolus needs to be grafted for closure. And that is done in conjunction with the orthodontist as well, as teeth are moved. And they'll typically do something like an anterior iliac crest bone graft to the alveolus to get them continuity of the arch, helps to support the nasal floor, and it can make room to either move teeth into that position or either make room for an implant to be placed down the road. They then, oftentimes, a lot of these cleft patients develop like a pseudo class 3 deformity, where the scarring on the upper jaw and the maxilla from all the surgeries, even the palatal surgery, doesn't let it advance as it should. So they have this, it looks like a class 3, but it's not because their lower jaw is so far out, it's because their upper jaw is so far back. So then later on in their later teens, they'll get an orthognathic surgery to move the upper jaw out. And that's, again, where the oral surgeon comes back into play for those patients.
Well, interesting. The cleft palate, because of cleft palate, the first American plastic surgeon was John Peter Mutterall, who in 1827 performed the first cleft palate operation with instruments that he designed himself. So cosmetic surgery in America originated because of the cleft palate. How is cosmetic surgery doing today? Let's start with face and neck lift. Are you doing many of those? Do you like those?
Yeah, one of my favorite procedures. So again, back to Alabama, one of the guys I trained with, Peter Waite, he was the first oral surgeon to be the president of the American Academy of Cosmetic Surgery. It kind of opened up the doors for a lot of oral surgeons to get into cosmetic.
Who was that?
Peter Waite, Waite.
From Alabama?
Yeah.
He was the first doctor to do what?
He was the first oral surgeon to be president of the American Academy of Cosmetic Surgery, which was largely plastics and other people of other specialties.
Wow.
Yeah.
I did not know that.
Yeah.
And so, because now, like say back in 87, I got to school, oral surgeons were all DDS. Now you see a lot of them with MD and they're dual trained and they're doing stuff in the hospital that used to be only MDs. And you're seeing Peter Waite was the first American oral surgeon to become the president of the American Academy of Cosmetic Surgery. Do you remember what year that was? Or
it was
about?
Yeah, I do. I would say it was 90, 91, if I had to guess.
I can't even remember that far back. But so what do you so is that if someone was in dental school right now and they said, when I graduate, I want to see if I can get accepted to oral surgery school, would you recommend an MD program over a DDS program? Or
you have to look at what their motivation was for doing it. I think that if they want to get out and they want to go into private practice and do dental alveolar, then they don't really have a desire to get the medical degree, then I don't necessarily think it's something that is going to help them. You acquire more debt. It's 2 to 3 years added onto your training, depending on where you go. So it's not something that's needed. But if you want to do expanded in hospital procedures and you have an interest in learning the medical curriculum, then it's a great deal. You do 2 to 3 years, you get a medical degree as well. And I don't think people who do it, I think they did a study, the AMUS, which is the American Academy of Oral Maxillofacial Surgery, did a study, and they found that most people that were dual degree, even private practice guys who did largely dental alveolar, most dual degree people did not regret doing the medical degree as well. So, if you have any desire to do it, then I think it's worth it. But if you're very clear about what you want and you just want to do dental alveolar and get through as quickly as possible, then you don't need it. It doesn't add much to your ability to perform oral surgery. But I think it does add to your ability to function in a hospital. You'll have a better understanding of a wider array of conditions. So, you usually get exposed to a lot of the different surgical specialties while you're in med school. So it does give you some benefit in that way.
So back to face and neck surgery. What are you what are you doing and all that stuff?
So face and neck surgery. So typically, it's been said the key to a good facelift is a good neck lift. So in most cases, the neck has to be addressed in facelift. So I'll do a lot of either segmentoplasty, some mini facelifts, some face and neck lifts that are more comprehensive. But the landscape in that is all changing as well. You have some skin tightening procedures that are coming out. So younger patients that have some neck laxity are sometimes candidates for non-surgical treatment, whereas we used to have to remove skin, pinch it up behind the ear. Now you can use these devices that actually tighten the skin non-surgically. So things are changing, but still the gold standard for people with neck and facial soft tissue laxity is a face and neck lift. And that's one of it's one of my favorite procedures to perform. Actually, I actually enjoy that very much.
And why do you enjoy that very much?
The soft tissue. I've always enjoyed the soft tissue. I mean, there's an artistry to it. There's a subtlety to it. The soft tissue and the geometry of the flaps, I've always found very interesting and rewarding. And the results, if you do it well, the results are outstanding. You make patients very happy.
Whenever you talk about the difference between a girl or a boy, you're called names, but is this a girl thing? I mean, if you did 100 of these cases, how many of them would be girls? How many would be boys?
It's less of a girl thing than it was, in the past. I think if you do 190 of them will be girls, 10 of them will be boys. Here in New York, in my patient population.
So it's still 90% a girl thing.
Yeah.
Poor girls. That's why it's so. And then they get a brow lift. I mean, is that so? So is it one of those deals where I've noticed in my life, nobody has one tattoo. They get a tattoo. 3 years later, another, and by the time they're my age, they got half a dozen. I've seen the same thing with cosmetic surgery. If they get one procedure, so you're saying the key to a good facelift is a great neck lift. So when they do the neck, they do the face. Is a brow lift like next on the list? Do they just start?
You want it to match. You want it all to match. So if the lower facial third and the neck is tight and makes them look like the 30 or 35, then you certainly want the brow to match. But everyone ages a little differently, and some people age in different parts of the face in a different way. I did a facelift recently on a very young patient who was literally begging me to do the facelift for 2 years, and I didn't want to because she was very young. She was early 30s, and she was a very attractive individual to begin with, but she did have some heaviness around the cheeks. And finally, she convinced me to do it, and we did a very conservative facelift, almost like a mini facelift. Although I don't really like that term, but it was basically a mini facelift. And she just looked fantastic. And I sat back and I was like, you know what, you were right. She doesn't need anything else. She doesn't need a brow lift. She doesn't need other things. She just needed the heavy cheeks and the heavy mid-face to be addressed. So every patient's a little different, but yeah, cosmetic surgery is certainly the type of thing where patients who get one treatment tend to get additional treatments down the road, certainly. And I don't think it's because it's necessarily addicting the way tattoos may be, but I just think that usually they're very happy with the results. And usually they're of the mindset that if they can change something with surgery, they will. So they're already predisposed to being willing to undergo to undergo surgery and undergo the knife, as they say. So I think it's for those reasons.
Yeah, mental health, it's important. I just thought it was just so bizarre when I was lecturing in Cambodia and Malaysia and Indonesia, where these young, beautiful Asian girls would pull their two upper first bicuspids and do Invisalign back for a year because they put their finger to their nose and chin, and if their lip touched, they pulled two bicuspids and pulled back. They did not want their lip to touch their finger from their nose to their chin. And I'm thinking, okay, there's 1 billion boys in Asia, and not one of them cares if your lip touches the line between your nose and chin. You're gorgeous. You're happy. It's just bizarre what people do.
Yeah, listen. What did you find the results to be from the post-op of those patients? Did they look better to you, or because you think it would almost hollow them out a little bit? It would decrease the support of the lips and the cheeks, you know.
Yeah, I'm not a fan of bicuspid extractions for so many reasons, but I'm sitting here thinking, I read a study once that the most beautiful person is someone 13 years younger than you. So, and I've seen this in Phoenix because it's a huge retirement community, and you'd be an 80-year-old woman, and the 93-year-old man across the street is almost stalking you and taking you out to dinner and all this stuff like that. And I'm just looking at these girls and saying, okay, if you were like the ugliest person that was ever born, just start aiming at someone 13 years older than you and skip all the surgery stuff. So there's let's keep going. Eyelid surgery. Do you like those?
Yeah, blepharoplasty. They're I mean, it's very the difficulty in eyelid surgery is really the planning, meaning knowing which patient to treat and which not to, and also in the amount of tissue that you leave behind versus the amount of tissue you take. Meaning, it's not about, like many cosmetic surgeries, it's not about what you take, it's about what you leave behind. So, you know, you don't want to overly treat somebody and remove too much upper eyelid or lower eyelid, because you can give them problems with closing their eye. You give them something called ectropion and some ophthalmologic issues that they can develop from that. But technically, the surgery itself is really very straightforward. You know, you remove skin. Some people remove a little bit of muscle as well, the orbicularis oculi muscle, and then you close them in pretty much a standard fashion. So they're easy surgeries to perform, but they're technically easy to perform, but they're tricky and they're complex in patient selection, if that makes sense.
That was very profound. You said cosmetic surgery is about how much tissue you leave and not take away. Is that how you said that?
Yeah, it's not what you take away; it's what you leave behind. I got that in Alabama too, I think.
That is and what is the shelf life of something like this?
Meaning how long before they would need additional treatment?
Yeah.
I think most of these treatments, like facelift, eyelift, it doesn't stop the tick, but it does turn back time. So meaning you can turn back time 10, 15 years in many cases, but they're still going to age. So a lot of people would say facelifts, you know, they're good for about 10 years and then you need a touch up. And that's probably true. Eyelid lifts, I think will last you closer to about 15 years.
And is buccal fat pad reduction, is that still a thing in Manhattan?
Yeah, that's I think maybe 1 or 2 years ago it seemed to be more trendy. Kind of comes in and out of favor. It's not a new procedure. They were doing that in the 80s and 90s when all the models wanted that kind of sucked in look. But I'll still treat. I've treated a lot of models actually that they seem like the ones that want that procedure done most often. And it can really change someone's face if you treat the right patient. And you don't over-treat them. You don't want to hollow people out. But if you treat the right patient, you can get great results. You can show much more definition of the cheekbone. You could have a slenderizing effect on the face. One thing that I try to do, if possible, is I try to look at a photograph of the patient's parents, because there's different types of people with midface or buccal fat. Some people have the type of buccal fat that's going to atrophy as they get older. And those patients, if you look at their parents, they'll have redundancy around the cheeks and the smile lines and all that. But some people just have genetically chubby cheeks. And if you look at their parents, the parents could be, wrinkled everywhere, but they'll still have chubby cheeks. Then you know that buccal fat isn't going to atrophy much over time. So in those patients, you could be a little more aggressive and take away a little bit more buccal fat. Whereas in the former, the previously stated patient, you know that they're going to have additional atrophy of the buccal fat over time, so you treat them more conservatively. So that's one little trick. But always understand that even when you remove small amounts of buccal fat, it may not seem like a lot at the time, but just from doing surgery, just from going into the site, you're going to get some scar retraction, some fat atrophy. So always remove less than you think you're going to want to remove, because the end result of a 3 to 4 months is going to be a really, can be a really dramatic effect, even when you only remove small amounts of fat.
When a patient says to you, everyone thinks my face is fat, do you say that's ridiculous? You haven't met everyone?
No, but I will.
So about slimming down the face, liposuction, face and neck liposculpture. Are you doing liposuction of the face and neck?
Yeah, I do something like that. No, that's a procedure that I actually do more in men.
Really?
Yeah. I'll send you a photo if you like.
No, I want you to start posting some of these on Dental Town. It'll blow their mind.
Yeah. But yeah.
And one of the things you can do is when you go to Dental Town, say you're going to post a case on liposuction. You can just do a search word liposuction. You can pull up. And that's the key reason Dental Town's a message board. Just like if you go to the Jet Propulsion Laboratory and they do a lot of that work here at ASU, they all use the message board format because it's an organizational database. It's not, whereas all social media is last in, first out, and you just have to scroll back. So yeah, if you got some cases, just do a word search and drop it in there and you'll blow their mind. You're blowing my mind right now. So men are getting more liposuction of their fat face.
I think men, a lot of men want that chiseled jawline, and that's the procedure that they tend to ask for frequently. So I've treated quite a few men with submental liposuction and jawline enhancement, things like that. The reason the term liposculpture versus liposuction is kind of goes back to that previous phrase about it's more important what you leave behind than what you take, right? So you don't just want to remove all the fat, but you want to be selective about where you remove fat from to really give an optimal aesthetic appearance. So that's why we use the phrase liposculpture, but it's basically the same thing.
In Manhattan, regarding fillers, Botox, injectables, you're starting to see some states start to have some turf wars where they're like, who can do this and not. Have you noticed any of these turf wars? And what are your thoughts on fillers, Botox, injectables? She's 25. She's a gorgeous young dentist, so she loves all things Instagram and beauty, and she wants to get into Botox. Would you tell her that that's a good idea for her new practice or a bad idea? What would you tell her?
It goes back to the same thing with implants, right? Like the landscape is constantly evolving, and if you don't evolve with it, then at some point, you're going to be left behind. So things like filler, Botox, especially Botox to start with, but even filler of the face and lip augmentation, that's certainly something that someone with a general dentistry background can learn to do and do well. And also, you can make mistakes and you can have bad results, but for the most part, if you're using the materials that you should use, it's all reversible. So you could give someone Botox and you could drop their upper eyelid because you give it in the wrong area. But after a few months, it's going to go away, right? By the time they're getting, the patients are getting, really upset, it goes away. The same thing with filler. You could inject filler into an area and have a bad result, but you could also inject something into it to dissolve it if it's a hyaluronic acid, right? Which is what they should be using. You can inject hyaluronidase into it and dissolve it. So these are procedures that general dentists should certainly be exploring if they have an interest in it. And I actually gave a Botox lecture to a group of general dentists back in April. A friend of mine, Nojan Bakhtari, and myself gave this lecture at NYU School of Dentistry, College of Dentistry. And you could see the turnout was great. You could see the enthusiasm. So I think it's something that's certainly going to be heavily incorporated into future dental practices and possibly even dental curriculum in schools.
Well, speaking of online CE, they come out with the average dental student had $287,000 of student loans last year. We've put up 400 online courses on Dentaltown for just $18, and they've been viewed almost 1 million times. And if you've got a lecture from that school, that presentation, if you have a lecture in your deal, man, I would beg for that. I'd walk all the way to Manhattan to get you to put one of those on Dentaltown. I'm Howard at Dentaltown. I was the first Howard, but the next Howard was Howard Goldstein. So he's Hogo at Dentaltown, and he's in charge of the online CE. He's in Bethlehem, Pennsylvania. And that's kind of close to Manhattan, isn't it?
Not too far.
But he's in charge of that. And these millennials, they say all the time, I want to learn this, but some of these weekend courses are several $1,000s, and I learned it on Dentaltown for $18. Yeah. Yeah, I love the how you say the dental landscape is constantly evolving. You need to evolve with it. I mean, everything I've read, Earth's had about 5 billion species, and they're all extinct except for about 15 million that made it to today. So if you're not constantly evolving, it's probably not a good long-term strategy. So what about chin augmentation? Is that more an implant, or does that go all the way back to what you were saying earlier? With those, that big long word, polyurethane custom implant deal? So
I just did a Q&A on my Instagram account on chin augmentation because I was getting a lot of questions about it. And there's a lot of discrepancy as to which treatment patients should get. And a lot of it is often because different specialties have different backgrounds and training and comfort levels with different procedures. I think that there's 3 main ways to augment the chin. The polyether ether ketone, the PEEK, isn't something that we typically do for the chin because you don't necessarily need that customizable chin implant. Most chin implants are silicone, and the reason is probably because the anatomy of the chin is less complex than the cheeks, and it's a midline structure, so you don't need the same level of symmetry as one side to the other. You know what I mean? So it's a little bit different. But the silicone chin implant's the common one. The other two, so silicone chin implants, one. The second treatment is a geniotomy, where the chin is actually cut and moved either forward, back, up, or down. And the third one is filler, which is used for the chin augmentation as well. For very subtle.
Okay, say that one more time. The 3 main ways. It was a silicone implant was 1. What was this? 2 and 3?
So 1 is a chin implant, usually silicone. 2 is geniotomy, which is cutting the chin and moving it into a different position. You cut the chin bone, and then you use plates and screws to fixate it. And the third one is filler. Injectable filler.
And would that be silicone too?
No, never. I mean, they make injectable silicone. Never let anyone use it for something like that. That would be a dense hyaluronic acid, something like Voluma. And that's dissolvable. Some people use Radiesse, which is a calcium phosphate or calcium hydroxylate or whatever, but I don't use that product. I only use hyaluronic acid-based fillers.
And how the chin surgery, how do you spell it? How do you spell that?
Geniotomy. It's GENIOTOMY.
And is that there she is. Is that a common thing, or is that a pretty rare?
It's quite common, and in my opinion, in most patients, the geniotomy gives the best overall result. It is also slightly more invasive than a chin implant, but the overall result is much better. Because when you move the chin forward, you're also moving the genioglossus forward and attachments to the hyoid bone. So if you look at the way the hyoid is suspended, almost like a hammock from the posterior digastric to the anterior digastric, as you move the chin forward, the hyoid tends to lift a bit. So when you move the chin forward, versus putting, if you move the actual chin forward and pull the muscles with it, you get actually a better tightening of the neck tissue as well. When you do a chin implant, you don't really get that, right? The other reason why I think it's better is because chin implants, especially if you don't fixate them with a screw, which I do if I'll do them, you can get migration of the chin implant. And it could erode the cortical bone over the lower, the mandibular central incisors. It can move. I've seen a lot of problems with chin implants, and have had to remove a lot of ones that were placed elsewhere. Whereas with the geniotomy, I don't see issues with them. I think I see a very, very predictable long-term results with geniotomy.
So do you think your practice is, what percent would you say is medical disease related, and what percent would you say is cosmetic related?
Even the medical disease related, I focus largely on reconstruction. So there's an aesthetic element to the reconstruction as well. So aesthetics is always in mind. When you talk about the more elective cosmetic procedures and the medically disease related procedures, I'd say it's somewhere about 50-50.
And so facial implants, would you say you already covered that? Because it's, you've already talked about, fillers, geniotomy, facial implants. What, did that miss anything that you've already talked about? Are there more?
We covered it largely. I think the big, the exciting thing with facial implants is the customizable peak implant for like cheeks and angle of the jaw, the mandibular angles. Those are pretty exciting because you can make them symmetrical. You can make them completely customizable with the virtual surgical planning, the computer imaging.
And what software are you using for these?
That is a software called 3D Systems, is what I typically use. I've tried different systems as well, but 3D Systems is the one I'm currently using.
And you like that one a lot? And and does that interface with your CBCT?
I upload the CBCT to their website.
Is I know this is so controversial. I don't even like asking the question because I don't think the lawyers even know what standard of care means. But is a CBCT the standard of care for implant placement in your mind?
I think so. I think not in every case, but if you're close to a nerve or something like that, then I think it's silly not to get one if you have access to one.
Do you have what brand of CBCT do you use?
I have an iCat.
Now, why is it that whenever I podcast an oral surgeon or a periodontist, they always have an iCat?
I don't know.
It's just they got all the specialists. Why does that to me that seems significant? Why did all the general dentists think all the other ones were great, but all the guys like you, they always go with an iCat?
Yeah, this one was in the office when I got there, so I haven't looked at the new ones to purchase, but maybe I will. I don't know. I'm open. I think the important things for me is I want one that gets the entire skull, the entire head. Some of them only do sections, and you have to kind of cut and paste if you want the entire skull. And I want to be able to do like the anatomage, the virtual surgery on them. So it needs to have the software that allows me to do that as well.
So then last but not least was the reason we're even doing this today. I posted one of your lip lifts, and Dr. Adonis Terazides told me that was your work. So is that kind of a new thing, or are you doing more of that? Lifting lips?
Lifting lips. It's not a new thing. I think if anything, it's kind of an older technique that was kind of repopularized, and it got really popular over the last few years. I don't do as many as I could, meaning that's one procedure where I'm very selective in the patients that I'll treat with it. And I'll turn a lot of patients away from it because you really have to pick the right patient. Otherwise you could have these really kind of bad outcomes. But in the right patient, the outcomes are outstanding. What's interesting about that post, I think, for most of the people that are tuned into Dental Town, is that's not just a lip lift, but it's a lip lift in conjunction with a maxillary prosthesis, the fixed maxillary prosthesis. So it helps for the restoring dentist to be able to make a prosthesis and control the lip length, especially in elderly patient population where they may have an atrophic maxilla and they may have a senile upper lip, which is like a long, flat upper lip. A lot of times they'll have to produce the restoring doctor will have to make a prosthesis that has a buccal flange and a sublabial flange just to elevate that lip to get more lip support. But the lip lift actually makes it easier for them to make a prosthesis because they don't need as much lip support built into the acrylic, meaning they don't need to build up as much acrylic to get the lip support. So that's the premise of that article that post is based on. And I wrote that paper with a prosthodontist, friend and colleague of mine named Katerina Kostianis, who's faculty out in Tufts Dental School. And she did the pros work on that. She did a fantastic job. And then a couple faculty members, one Patrick Lewis at UAB, fantastic surgeon, and Daniel Gibbons, faculty in prosthodontics at UAB, also an excellent individual. So the paper, it's I think it's more related to a lip lift in the dental patient versus just a patient that just wants a lip lift for purely cosmetic reasons.
Yeah, I notice all the dentists realize when they're, say you're watching the news and the person shows their upper teeth and upper gums, it's a young woman. By the time they don't show any upper teeth and they're showing the tops or lower teeth, they're past 65. But when they're showing no teeth and their lower gums, they're 80. And so I can see how a surgery like that starts, people would want to start lifting the curtains to reverse gravity.
Yeah, a little bit. Yeah.
Someone on Dental Town posted, is anyone offering Kybella, an injection that melts a double chin in their practices? If so, what has been your experience with it at mykybella.com?
Okay, so Kybella, it was popular 2 years ago. I felt like it was very popular. Now I don't hear as much requests for it. I don't personally love it. I think that in patients who just need a very little amount of submental fat removed, it can be okay, but you're still going to need 2, 3, sometimes 4 or 5 treatments. And those treatments can be quite, that can be quite expensive. And you also have to do the treatments anywhere from 4 to 6 weeks apart. So you're talking about half a year, 6, 8, 12 months even before you're done with treatment in some cases, versus just going in there and doing submental liposuction, which is a one and done procedure.
So you would rather do what instead of Kybella? You would rather do liposuction?
Yeah, people get very afraid when they hear that because they think of it as an invasive surgery, and I could understand that. But the reality of what submental liposuction is, it's not. It's really not what most people are expecting. You make a tiny little nick incision under the chin, and you take a very small tube and you suction out some fat. And that's really basically the long and short of it. They're a little swollen, they're a little bruised, but by 10 days, they're pretty much good. And by 2 to 3 weeks, almost all the swelling is gone.
And you're calling that a submental liposuction?
Yeah, yeah.
And so that's just faster, more predictable. And Kybella, you're saying that you're going to have to be on this for a long time before you notice anything?
Yeah, it's multiple sessions before you get any kind of appreciable result. And in the long run, it's more expensive. And even after Kybella, it's not like there isn't any downtime. There is. You'll get a bullfrog appearance of the throat where you get a swelling of the submentum and the tissue around the neck. And there's some bruising. There's some numbness and tingling that's there. Most patients get these little lumpy nodules that take a few months to dissolve and break down. So it has its downsides too. If someone had a very small amount of fat under the chin and just wanted that addressed, then maybe that they're a reasonable candidate for it. But in most cases, patients are much better served with submental liposuction, in my opinion.
Well, that's a pretty intense opinion. instead of, I guess, just taking the pill isn't going to be it. Now I want to get, are you still good for time? I mean, my gosh, you're such a rock star. I don't want to stop. Oral head and neck cancer. What should these young kids know? What I don't understand this. Walk me away from these thoughts. It's like if you take a patient and it's a girl and you turn her upside down, the insurance pays for pap smears, cervical lights, all these procedures, and they really taken a bite out of cervical cancer. I mean, it was like 50,000 a year, and now it's down to 12. But you turn that patient right side up, and the dental insurance companies don't want to pay for oral screening. There's no big media about oral cancer. It's not paid for, and we've still been at that 50,000 mortality the whole 30 years. So why do they take all that? Why does all that knowledge only apply to a female cervix and not a male or female mouth with oral head and mouth cancer?
I mean, that's a tough one. Where I see that most clear, what you just described, where I see that most clearly is really with my Medicare patient. I take Medicare, A, because I like the patient population, and B, because I find a social responsibility to the population as well. So with the Medicare population, they come in and Medicare won't cover oral biopsies. You know what I mean? They say that they do, and there's some loopholes, but they really don't. And these patients, they consider them dental procedures. And as you know, Medicare doesn't cover dental procedures. There's nothing dental about a lesion that could potentially be a cancer. It's their overall health. You know what I mean? It's not a dental issue. It's not a medical issue. It's both and all, if you will. So I agree with you. I don't know why the neglect is there, but I think it's probably there because it serves as a loophole for the insurance companies, meaning if it's in the mouth, it's dental, so they don't have to cover it. And
so you're saying they don't pay for oral cancer biopsies? Is that the Medicare?
That's been our experience with trying to get them covered.
Yeah, that is so weird how people
same
they don't think the mouth is part of the body. I don't know what part it is. So Medicare doesn't cover dental. So for international listeners, the Medicare is the federal government for the over 65, and each state has its own Medicaid, which was the most confusing thing about Obamacare. I mean, I don't want to talk politics whether you like it or don't like it, but what I don't understand from a business is everybody that was on Medicaid had no idea Obamacare was affecting Medicaid. It was a horrible brand it was like Coke coming out with new Coke. I mean, he should have just focused on Medicare because everybody would have understood what he was doing, but nobody knew. Out here, like in Arizona, it's called Access. No one knew that Access was Obamacare or covered by Obamacare. But oral head and neck cancers really changed with HPV. And again, I don't see my homies talking about Gardasil 9 by Merck. I don't, they say they're not, because it was related to Michael Douglas and oral sex. I mean, obviously we're not having that discussion. And it's like, well, you're either a doctor or you're not. I mean, do you think the people listening to you right now should be having a discussion about an HPV vaccine to prevent oral cancer in their chair?
Yeah, I mean, I think that the vaccines like Gardasil and there's some new ones out, I think if you treat them for that, you're essentially treating them for prevention of the HPV positive squamous cell cancer that people get in the oral pharynx. So I think what we're going to see as the generation, when did Gardasil come out? Like the early 2004-ish, 6, right? And they started treating teenage women initially for that. And then they expanded to offering it to teenage boys as well. So I think as the population grows, you're going to see less oral pharyngeal HPV positive cancer. The important discussion, or the discussion that people have to learn how to have is when we see it in a patient, how to educate them about how they got it in a way that's sensitive to the nature of the transmission, meaning they did get it through certain activities, especially when there's a spouse involved that doesn't have it. That's the part that's the discussion that tends to be tricky. And there are ways to kind of do that in a way that doesn't send them home in not only having a diagnosis of cancer, but also in turmoil with their loved one or spouse. But I think that in treating just in getting the vaccine as young adults, you're going to see a drop in the incidence of HPV positive oropharyngeal cancer for sure.
You last but not, I can't believe you've gone over. My gosh, you're just so nice going 20 minutes of overtime on this show. I could go on for 40 days and 40 nights. You're so amazing. I'm not going to do that to you. I'm begging for my homies, if you have any of these presentations, to put them on online. See, I mean, there's 2 million dentists on earth, and we have a digital connection to half of them. We have 1 million verifiable, auditable connections digitally. Because when I've lectured in 50 countries, and I can't believe it almost makes me verklempt when some little girl in Somalia or Nepal. I walked into the dental school in Nepal, and when the dean realized it was me, she broke out in tears because she said, "My God, your dental town stuff, our textbooks are all 25 to 30 years old." She told me in her dental school, all the donated textbooks were from a church in Pakistan. So they're Arabic, and another church in China, so they're Mandarin Chinese, and they speak Nepalese, but the international language for dentists is English, and they just love those courses. And we only charge, we don't tell anybody, but we only charge the $18 in the rich countries, not the poor countries. And so if you're poor, you already know this. If you're rich, you're like, what?
Now, Howard, can I ask you a question? So now, with regard to dental town for students, is that something that you've already explored, reaching the student population, or maybe in the future intend to explore more for a way to educate some of them in some things that they may not be getting in their school curriculum?
Absolutely. All our online C courses are free for all dental students anywhere around the world. And the most sad comments on them is, I'm watching this lecture right now during my dental school lecture. Yes. So I'd rather put in my headphones and listen to this online CE course on Dental Town than listening to the guy talking right now in school. And also I think there's something they love, millennials love about the hour format. I mean, they work out for an hour, committing to an all day lecture Friday from 8 to 5. I mean, it's hard to even sign up for it, let alone go to it. So they like those little hour increments. I think that works better with the human mind. Last but not least, what would you say, how can we general dentists have a better referral relationship with our oral surgeons? What do you look at us and say, yeah, I like that? And what do we do to you that you say, gosh, I wish they wouldn't do that?
I think communication, if you can effectively communicate with anyone that you're working with to take care of a patient, it's always going to be better for the patient. And the doctors involved are always going to have more of they're going to feel more rewarded, and they're going to have a better experience treating that patient. So personally, I don't choose to work with many different referring doctors. I don't cast a wide net. I choose to work with fewer doctors that I communicate well with, B, share treatment philosophy with, so that treatment for the patients makes sense on both ends, and then C, that I actually like and I enjoy interacting with. Because if you like someone and you enjoy interacting with them, you're going to be more eager to send them that note. Hey, I just saw a patient so-and-so, they're doing great, or what do you think about this? And that's when patients get the best care, and that's when it's the most fun for us. So I think, choose doctors and referrers and referring doctors. Choose people that you enjoy working with, that you communicate well with, and that you think you have a similar mindset into treatment philosophies. And I think that's the best way.
By the way, that case you have, Hill Plastic Surgery, that video on Instagram, when you make a post on Dental Town, it has the icons for media or YouTube, okay, so you can drop that right in there. I love your videos. Huge fan of your Instagram page. His Instagram is just it's Instagram.com/Dr.Hanna. DOCTOR.Hanna, 21,000 followers. You're a legend in my mind, everyone's mind. Thank you, Dr. Adonis Terazides, for hooking me up with this man. Todd, it's so amazing. Thank you so much for all that you do for dentistry, for oral surgery, and thank you so much for coming on the show and talking to my homies today.
Thank you, Howard. Thanks for having me. It's been a pleasure.
And if you got an online C-course to make, man, that would be so cool.
Got it.
Okay, buddy. Have a great day.
You too. Thanks.